Thank you, Dr. Pinto, for being with us. Let's start by setting some context to this conversation. What exactly is COVID-19 and why is it so different from the flu virus?
COVID-19 is a coronavirus. It belongs to a family of viruses which have spikes on the outside when looked at under an electron microscope. So it looks like the crown, a crown, or a corona around the sun is also what it has been described as. These group of viruses, a certain subset of this group of viruses causes the common cold. But the three most notorious ones that we've seen so far in the recent past are the SARS epidemic, the MERS epidemic, and what we're currently facing with, which is the COVID-19 epidemic, which we're facing across the world. How is it different from the flu? So let's go step by step. Let's start with the R0. So the R0 is a measure of an infectivity of a virus. It tells you that if you introduce a virus into a native population, a population which has no immunity, what is the probability of an index case, a person suffering from it, spreading it to others? When it comes to the flu, that number has been estimated to be about 1.3. So an infected person will, on an average, spread it to about 1.3 individuals. For the current virus, for the coronavirus, for C19, it's estimated to be somewhere in the order of 2 to 3. So it does appear to be more infective than influenza. The next thing is the incubation period that we look at. So now you've got infected. How long will you remain asymptomatic before the symptoms manifest? And for the flu, that's an average of about 3 to 4 days. While as for corona, it can be as long as about 14 days. So that makes it unique in that you could be spreading the virus for 14 days without the knowledge that you are actually suffering from it. The next step is, okay, you've got infected now, and what is the probability of you having severe disease? So when it comes to the flu, about less than 1 to 2% of individuals get hospitalized with the flu. While as for the coronavirus, what we've seen is as high as close to 20% of individuals getting hospitalized. When it comes to severe illness, it can be somewhere close to 5% of individuals needing intensive care. When you talk about mortality, the flu on an average causes death in about 1 in 1,000 individuals. So 0.1% is the mortality for the flu. While as with the information that we have right now, it seems that it's somewhere around 2 to 3% for the coronavirus.
And it disproportionately hits older people.
Absolutely. So that's the other thing unique about the coronavirus. Although the flu as well hits older people more than younger, but in this case, individuals who seem to be above 50 to 55 years of age seem to have a much poorer outcome than younger individuals. The mortality can be reasonably high, especially in individuals who are above 80, and that's what we are seeing in Italy. Of course, the other difference between the two is that we do have a vaccine for flu. We have some sort of immunity in the population because we've experienced it over the years, whereas this is a novel virus. This is being introduced into the human population for the first time, and that comes with zero immunity to it, which is why we're experiencing such a pandemic.
Okay, just to go back to the origin story once again, how do you think humans picked it up? So this is clearly something that was moved from animals, correct?
Right. So the coronaviruses are known to infect animals. So we know that bats, we know that there are certain other vectors, certain other animals which are carriers of the virus. The current postulate is that bats were probably responsible for the current horseshoe bats, for the current epidemic, with a possible intermediary that we are not aware of yet. When it comes to SARS, it was again assumed that bats were responsible. MERS was bats. There were camels involved as well in the transmission of MERS. The current hypothesis is that it's the horseshoe bat which transmitted it to human beings. That's the current hypothesis.
On the infectiousness part, the fact that the COVID-19 virus tends to first embed itself in your upper respiratory tract, does that have anything to do with the fact that it's more infectious than say the flu or maybe even the SARS?
No, so that's fascinating. So if you see the couple of studies which were published recently in the New England Journal, where they did nasopharyngeal swabs, they did nose swabs of individuals who were infected, they found a very high quantum of virus. Even there was one individual who had not yet become symptomatic, because this was a cluster of individuals who were living in a family. Even before becoming symptomatic, he had a significant viral load in the nasopharynx. And for sure, I wouldn't be surprised at all if that's one of the major reasons why the infectivity is a lot higher. So the shedding seems to be a lot higher. For example, in SARS, one of the reasons we were able to control SARS so well was that the shedding really peaked or was maximum when the person was symptomatic. So you knew that the person had symptoms, you quarantined him or her immediately, and kind of the problem was solved for that time. Whereas when it comes to corona, we know that the shedding is very high even in the early stages of the disease, when an individual is completely unaware of the fact that he or she is ill.
What are the common means of transmission, number one? And number two, what are the common features, common transmission methods, and what are the misconceptions around transmission that we need to be aware of?
So from what we know, the most common method of transmission would be droplets. So airborne droplets, which generally happens when a person coughs or sneezes, or even breathing in itself would generate a few droplets that would hang in the air, which is where the whole concept of social distancing comes into place, because one assumes that one carries a cloud of airborne droplets around oneself, which is about 2 meters in length. If anybody walks into that cloud, there is a possibility that the person inhales the droplets, and that leads to infection in the individual. As of today, we presume that this is the commonest modality of spread, and our information comes from the fact that individuals with close contact seem to be getting the infection at a higher rate than individuals who just casually share a bigger space, for example. The other modes of transmission that are being postulated are actually airborne. So airborne would mean that something which is suspended in the air for a prolonged period of time. And a recent study again which looked at surfaces. It was a simulation study where they looked at surfaces and they looked at the air, and they found that different surfaces seemed to behave differently. So it stayed for a shorter time on a surface like copper, it stayed for slightly longer on cardboard, it stayed for a really long time alive on a surface like plastic for some reason. Again, we don't really understand exactly why this happens, but it does stay on surfaces for up to 36 to 48 hours when it comes to things like plastic. And therefore, one would presume that one way of getting infected would also be touching these surfaces and then touching your face and inoculating oneself in that way. There is a hypothesis that there's a fecal-oral route of infection as well, which was what was seen in the SARS epidemic in where they had a closed society where the faucets were leaky, or the piping was leaky, and that led to a lot of contamination in the air because there was a lot of fecal aerosols in the air. And it has been documented that corona is also found in fecal matter, so we don't know if that's a method of transmission as well. I think these are primarily the main modes of transmission that are being considered right now.
So on the surface question, so you mentioned cardboard. Should we worry about, for instance, ordering in food?
The problem still with that is that, okay, the surface may be fine, but you don't know if the handler is infected or not. Correct. So at the time of dropping it to your doorstep, he or she could be infecting it at that particular point of time, and so the clock starts from that minute, right? So that's the variable, that's an unknown.
So what would you advise in those circumstances? I mean, so I've seen, for instance, newspapers now have advisory saying the newspapers are produced in sanitized conditions, but the problem is the person who delivers your newspaper, we have no control over. Right. So what does one do in these circumstances besides shifting to digital editions of newspapers?
Right, so I think prudence is what is warranted. I don't think there is going to be a situation where you can be 100% certain that you're safe in that sense. So if you have a delivery handler, rather than focus so much on the surfaces, which again right now is being considered as a lower probability mode of transmission, you focus on the aerosols that the delivery boy or girl might bring along with him or her, and therefore I would advise people to have them drop it off outside your door, wait for a good 10 minutes or so, hope that the aerosols by then have settled on surfaces and they're not in that cloud, and just pick it up after 10 minutes or so, and then wash your hands before and after. That's the bare minimum that you would do.
So pretty much the single biggest piece of advice that I've seen consistently, and you seem to be agreeing with it, is wash your hands.
Absolutely. So that's one thing without a doubt. If you look at the details, the surface of the virus is made of the protein absolutely dissolves and disintegrates in the presence of soap. So I think the strongest advice is to wash your hands with just plain soap and water. You don't need to have fancy disinfectants, which will eventually get out of stock if everybody wants to just focus on disinfectants. But just plain soap and water seems to work very effectively against the virus, and doing that as frequently as possible is not a bad idea.
And what about sanitizers, hand sanitizers? I mean, clearly soap and water is preferable to hand sanitizers. What are the circumstances that warrant the use of hand sanitizers?
I, for example, work at a hospital, so it's a higher density of sick individuals there. So I work in a higher probability setting of getting infected. Going over and above would be warranted for circumstances where you think that the probability of getting infection is higher. That being said, hand sanitizers also come in handy if you're traveling and you may not have access to soap and water everywhere. I recently heard that Kerala has introduced soap and water dispensers at bus stops and places everywhere, which is fantastic, But unfortunately, I don't think all of us may have access to that kind of those kinds of services. In which case, if you have a portable, handy hand sanitizer, I think that kind of is not such a bad idea.
And is there a recommended alcohol content in the hand sanitizers?
So again, from what I know, 70% is kind of the cutoff. You need to be above 70% for it to really be effective. Anything dilute does not work so well.
So on the myths, let's just address two myths straight away. One is, does it transmit through blood?
So not that we are aware of.
The second one, and this is, I guess, I can't tell if people mean this as a joke or not, which is that Indians have hardier immune systems, so therefore we don't have to worry about this virus.
Again, I'd be happy if that were true, but I don't think there's any solid reason to believe that.
And we discussed briefly the fact that it lodges itself in the upper respiratory tract. What's the trajectory of the virus after that? And at what point does it get really critical care, ICU kind of situation?
So I think the tipping point is really when you experience shortness of breath. So I think that's when you should really be concerned. So if it's at the stage of having a cough or a mild sore throat or fever, I don't think there's any reason to. I mean, you would visit your doctor as you would routinely visit your doctor, but I don't think there's any reason to go to a hospital or to seek admission into a hospital. I think shortness of breath is what we're really concerned about, because if you are short of breath, it's likely that it's kind of an acute respiratory distress syndrome setting in, which is what is concerning. You would need supplemental oxygen to begin with, and if things get worse than that, you might need ventilation at some point of time.
So what you're effectively saying is that. So what I've typically heard is if you have a fever, is when you call your doctor. But what you're additionally telling me is, besides the fever, what you really need to look out for is shortness of breath. At what point do we contact our doctor?
So you would contact your doctor even for a fever. I mean, but it's the triaging in terms of would you go to a tertiary care center or would you call your family doctor is, I think, where the judgment call is. And I think if it's a fever, you could speak to your family doctor. I think most family doctors would advise you to take the usual, just take simple paracetamol, sit it out and see if, we would ask for questions in terms of warning signs. Could this be bacterial? If there are certain warning signs, if it's a person who has underlying lung disease, for example, we might want to get a chest radiograph done. We might want to investigate more at an early stage. But for most individuals who are otherwise healthy, who are young, who just experience a fever, you would generally just sit it out for a day or two rather than rush to a hospital. So
plus the fact that you don't want to overwhelm the hospitals by running there with.
Absolutely. So tertiary care is not where you should head when you have a fever. A fever would, under normal circumstances, warrant a call to your doctor and a visit to your doctor, and I think that's fair. That's what the starting point should be. If despite the initial measures of just hydrating yourself, having a paracetamol, resting as much as you can, if despite those measures one feels that things aren't getting better in a day or two, that's when you probably want to escalate it further.
You keep hearing of flattening the curve. What does that mean?
So the normal trajectory of an epidemic or a pandemic is that initially you have a few cases, and those few cases go out into the community, they mingle with others, and then there's a sudden sharp spike, which is what the spike in the epidemic curve is. Now what happens is, when that spike comes too soon and with a great magnitude, the healthcare system gets completely overwhelmed by handling the situation. So individuals who may not have a poor outcome because of the severity of the disease actually end up having a poor outcome because of the lack of resources, because the resources that would ordinarily be fairly straightforward, something simple like as oxygen, something as simple as a non-invasive ventilator, which would ordinarily be very easily accessible, suddenly become inaccessible, and you would lose individuals as a result of that overburdening of the healthcare. So flattening the curve is an attempt to try and completely flatten that peak of the curve, so that even if you do suffer from an epidemic, the epidemic is of a magnitude that can be handled by the existing healthcare resources.
So what you're saying is the absolute number of patients will not change, but the time period in which they show up at the medical system changes.
Absolutely. So if you look at it 3 years down the road and you count the number of people infected, maybe the numbers would be the same. But in the short term, you would want to try and flatten it out, or you would want to stretch out the number of people getting infected over the course of a year, over the course of time, rather than have it all burden your healthcare system at the same time. And I think it can't be said enough that what we are trying to do is not out of a fear on a case by case, on an individual by individual basis. A healthy middle-aged man with no underlying diseases is unlikely to suffer a severe consequence of the virus. But an elderly person, and if all the elderly people get infected at the same time, we are going to completely overburden our healthcare system. So yes, we don't want people to panic. The idea is not to panic, but the idea is to be cognizant of the fact that there are vulnerable people in our society, and we need to do our best to make sure that they have access to the healthcare when they need it, rather than overburden the healthcare system and have them suffer poor consequences as a result.
So more than once you've used the term social distancing. What does that actually mean?
So social distancing again comes from this concept that every human being generates a cloud of droplets around themselves. If you sneeze, if you cough, if you breathe, you almost live in a cloud of droplets around yourself, and that cloud is estimated to be about a distance of 2 meters. So I think it's roughly your arm span, which by and large equals your height. So if you're about 5.5 feet in height, your arm span would be roughly the same, and that comes somewhere very close to 2 meters, which is the distance that's recommended. So if you keep that kind of distance between you and people around you, you're very unlikely to A, get infected from them, B, infect them. And I think this is extremely important for a virus in which you could be shedding while you have no symptoms, right? So if you were ill, and you would, it would be fairly straightforward that you would just have to go home and quarantine yourself and stay away from others. But you could absolutely be ill and have no idea that you are ill. You could absolutely be carrying the virus, and that's where social distancing plays a very important role. So social distancing assumes that I could be infected and the person in front of me or the person I am with could be infected, and therefore you maintain your distance of about 2 meters from them, ensuring that you either don't get infected yourself or you don't pass on the infection to the other person.
What do we mean by community transmission? So right now the understanding is that almost all of the cases that we have in the country are somehow imported from the outside.
That's right.
What do you mean by community transmission, and why should we worry about that?
So when there is a virus which is kind of imported in that sense, when it comes from another country, the first stage is people bringing the virus into the country. So therefore all your efforts can just be focused on travelers, which is what we've currently done. The screenings that are happening at airports, the detailed histories of travel which we're seeking when we test, are all geared to the assumption that right now we are in a phase that most of the disease that we are seeing are in travelers. Eventually, we will see individuals who possibly have a milder form of the disease and therefore not present themselves to a healthcare facility, not get tested, who will be out there in the community and spread it. And that's when the virus would start spreading from a person to a person. That's the person-to-person spread that we are really afraid of, because that's when things get a little out of our control.
And what do you think about the seeming success with drugs like chloroquine, or there's a drug by Gilead Life Sciences, Remdesivir, and so on? There seems to be some optimism around the use of these drugs, and especially if you look at some of the results in China and elsewhere. What do you make of that?
So I think a lot of these drugs were tested in the previous corona virus epidemics, and they seem to have promise at that stage. I think the safety was kind of proven at that stage, which kind of made them very attractive targets. So we knew that they were safe. Hydroxychloroquine and chloroquine have been used forever, so the safety profile is known, and that led to the concept of trying to repurpose these drugs for the current viral epidemic. So initial data from China suggests that a combination of hydroxychloroquine and azithromycin might show promise. The study that was published in a small population showed that the viral loads on day 6 significantly decreased with the combination as compared to controls who refuse to take the drug. Of course, that comes with its own biases, why did they refuse to take the drugs, etc. But that's shown promise. And again, we know it's safe, so it's something that is definitely worthwhile trying. The antiviral drugs that are undergoing testing right now have also shown some promise. There's a Japanese drug called Favipiravir, I think that's what it's called, which has also shown some promise in trials. But again, these are not going to be the highest quality of evidence. But right now
it's a crisis. So you try what you have.
We try what we have.
What do you think about the scope for vaccine development? Is it easy to develop a vaccine for the coronavirus? That's number one. Number two, we assume that vaccine development typically is a very long drawn out process. But given the fact that every government in the world is literally throwing the kitchen sink at the problem, do you expect the process to speed up this time?
I think the delays often happen because you have to go through a series of phases. Yeah, you have to go through a series of tests. There's safety, then there's efficacy, and then you actually roll it out. I think once the safety phase gets done, a lot of people, given the fact that we don't have much, I think it would not be that challenging to have people enroll for a vaccine in terms of a trial, an actual vaccine trial. I think it's going to be accelerated for sure. But the phases are the stages of vaccine development are there with a purpose. We don't want to cause more harm than good. So I think we can accelerate it only up to a certain point, because we wouldn't want to jeopardize anybody's health by going too fast and then realizing that we made a mistake.
Do you have a view on, the UK is clearly turning its strategy, but they initially went with the sort of herd immunity strategy. Right. Do you have a view on that? It seemed interesting intellectually, right, but I'm not sure in practice what that would look like, and that appears to have been the conclusion that the UK has finally arrived at.
Right. So I think herd immunity comes at a price, especially when you're dealing with a virus that has the potential to kill. Then herd immunity is going to come at the price of death. You are going to lose you're going to lose a significant number of individuals, and yes, you will develop herd immunity in the long run. The place where there are only two places where herd immunity is very attractive. Number one, if there's no serious adverse consequences of an infection, in which case you would rather have the population get it done and over with in that sense. The second place is where you have an effective drug that's available. So you would let people get sick, you would offer them the drug, they would heal at the same time. The huge chunk of individuals who do not have a severe enough infection to need the drug would become immune. So I think that's where it works really well as a strategy. I don't think hypothetically it was a great strategy to use in something in a virus where the Chinese experience and the Italian experience is showing us already that mortality is a serious concern, severe outcomes in terms of being on ventilators, etc., are a serious concern, and the fact that we have no drug. So you're effectively saying okay to the fact that we will lose some individuals. So and that's okay a price to pay to develop herd immunity, and I don't think that's a good strategy.
But the fact of the matter is that at some point, some very large proportion of us are going to get infected. That's right. Either through a vaccine or through infection, right? Sure. One way or another. So another potential strategy would be to actually go do whatever it takes to flatten the curve. Right. But once you flatten the curve, you start releasing some non-vulnerable populations, right, out of a potential lockdown situation, right, to acquire some level of herd immunity. Is that a viable strategy? And
I think that's kind of what's going to eventually happen, right? So we can't be on lockdown forever. I think all of us know that. So because we are at stage 2, because we are at an early stage of the epidemic, that's why we are trying our best to flatten the curve. But there is going to be a stage around the corner at some point of time where we will have to accept that whatever efforts we've done possibly have paid off. We're kind of plateauing at some level. And that's when people need to get back to work, people need to get back to the jobs they're doing. At that stage as well, we are going to, as you rightly said, the vulnerable population, we're still going to be advising them to not step out, to try and avoid people as much as possible. But the bread earners of the house, the productive population, people will kind of have to start going back to work again, and the herd immunity is going to happen.
And that's where we need to sort of re-emphasize the point that the virus is not the problem. The medical system is, or overcrowding of the medical system is the problem. So therefore, non-vulnerable populations coming out of a lockdown at a later date is okay.
Absolutely. So the last thing we would want is that people getting infected and the paranoia associated with that infection, with the knowledge that I am infected, we wouldn't want that knowledge to do way more harm than the virus itself, because we know that in most individuals the virus isn't going to cause that much of a harm, but the paranoia associated with it, so tomorrow I go and I test, because we've seen this happen with HIV as well. At some point of time, people would get tested, people would get, would see a positive result, and then we've had suicides associated with it. We've had people think that this is it, this is the end of the world for them. We definitely don't want that happening. We want to send a message out strong and clear that if you do test positive at some point of time, whether it's now, whether it's even a month down the road, if you do test positive, the odds are in your favor by and large, unless you're extremely vulnerable. The odds are by and large in your favor. So we do our best to try and not get infected, but in the eventuality that if we do get affected, we don't let this overcome us. We don't let this overpower us at that point.
We're coming to the end, so let me ask you a few things. So you also, a related problem, you sort of hinted at it, is the social stigma associated with something like COVID, where we are seeing people being not so nice to other people because there's some suspicion that that they may be infected and so on. Do you want to just quickly comment on that?
So I think what's important is something like universal precautions. So assume everybody is infected, assume yourself to be infected, and therefore think of the person who you potentially think is being infected as being no different from you. So stigmatizing a person would be almost being in denial, because you very well could be infected right now. And I think stigmatizing the disease is not the answer, also because we can't reiterate enough that the disease in itself is not necessarily severe, it's not necessarily lethal for a majority of the population, and the probability of you infecting others without having any symptoms whatsoever is reasonably high as well. So I this is a great leveler in that sense, right? So we're all in this together. So there's no reason, there are no high risk behaviors that could that result in you being infected. So so shaming people who are infected in any way does not make sense at all. And I think that's really the message we need to also communicate to people who may not have access to the kind of information that we do. People who work for us, our people, our staff, people for whom it's just the whole city is on, the whole country is in lockdown right now, and that's all they see, right? So for them, this is a really huge problem that they need to be really afraid of.
Do you wish all of our political leaders would actually reach out there and basically communicate this? Because from what I can tell of people, wage earners and so on that I speak to, they are terrified, and they're terrified mostly because they don't know.
Absolutely. And I mean, to be fair, this is a challenging exercise in communication as well. This schism that we are seeing, where on one hand we're telling people the concept of flattening the curve, stay at home, on the other hand also telling them that if you do get infected, there's hardly anything to worry about. So that's a difficult message for anybody to understand, and I think a ton of work needs to go into that, because we might also end up with a scenario where we've been lucky enough, we've not had the worst in terms of the pandemic, but we've had the worst in terms of the paranoia, and we don't want that happening.
And there is no danger of overreaction here, right?
No, I think we need to do as much as we can, and there's as somebody wise said, a few months from now, when we look back, we will never know whether we overreacted, but we will definitely know if we underreacted.
I think that's a great way to put it. Couple of last questions. How do we better prepare for pandemics like this, A? And if you had the levers of policy with you, what additional thing would you like governments to be doing?
So I think a lot of good is going to come out of the measures that we've taken even for this. Simple things like cough hygiene, simple things like making sure that we don't overcrowd as much as we can. Measures where social distancing, I mean, we wouldn't want that to be a regular feature of our lives, but just in terms of hygiene, just in terms of the sensitivity that one needs to have if one has a cough, if one has a cold, And I think spreading that message across is one of the things that the government can do for life, for generations to
so
come.
what you're saying is there is effectively some good that can come out of a public health crisis like this. So a good example in the city that we live in, Mumbai, is the BMC saying that you cannot do public spitting anymore, for instance, right?
Absolutely.
So-
Unfortunately, it takes an epidemic or a pandemic to put that into
is
place.
fine, yeah.
But once it's in place, I think changing that behavior for generations to come has a lot of, I mean, it's a big investment, I think, into our future. When I sit in my clinic, for example, have started regularly using a mask, which I was a little callous about maybe before. And I see that it's not the cost to benefit ratio is skewed in favor of me using that mask all the time. So simple measures like that, being as cautious as possible in terms of, especially when people are sick, I think that's going to change a lot in the long run. So when you are sick, you do your best to not transmit that, and I think a lot of benefit might come out of a policy like that.
And would you like to see the government doing anything more, anything specific that you'd advise governments to be doing?
An investment in healthcare is something that that's the bottom line for everything in terms of the next few weeks will tell us whether we are prepared in terms of the number of ventilators, in terms of the healthcare facilities that we have, and I think we need to ramp up that to the best we can in preparation of future epidemics like this.
Right. I mean, healthcare should never be an afterthought. It's something that you should have in place from the get-go, because it's a wall between human beings being able to function versus otherwise.
Right. I think we need to invest a lot in preventive medicine, for example, rather than react to situations.
Sure. So public health, a lot more attention to public health.
Absolutely. I think that cannot be emphasized enough.
Lance, I've said this to you before, I'll say this to you again. I think on behalf of all of us out there, we owe a huge thanks to not just you, but to everyone in your profession, in the healthcare profession. I don't think you guys are appreciated enough, and I think this is a good sort of window for us to express our appreciation to everyone in the healthcare profession. The parallel that I always draw is, during the 9/11 attacks in New York, this is equal to the firefighters who were climbing up the stairs while everybody else was climbing down. That's what you guys are doing. Thank you.
Thank you, Reuben.